Hello, everyone. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. It's a great pleasure to be back after a couple of weeks of absence, and I know the team has been amazing. We are meeting today after they just celebrated International HIV Day, but today we are going to be talking HIV, one of our own Dr. Boghuma, Titanji, Professor Boghuma, who is a trusted authority when it comes to this subject. And today we shall be talking the future of HIV treatment and prevention and the hope for a cure. Ladies and gentlemen, if you are joining for the first time, this is Cameroon Town Hall for Healthcare Professionals, a platform that meets every fortnight to discuss healthcare issues that affect our country and to look at a perspective from both the country and what happens abroad and just how the diaspora can be of help. Today, we shall be giving some time and going around. We are 14 in number now, but before we get to a full house or a quorum to start, let me just check in with some co-moderators and, of course, the chair who is here just to know how your week has been from the last time we met. Hello, Muno.
Oh, Elvis, thank you. And happy to see you. And I think you're still in Africa, so during the public health conference, or you're back in the US? Are you back?
Still in Lusaka, and leaving for Lusaka to Zimbabwe tomorrow.
Wow. So enjoy your trip, and it's been a wonderful time for me so far. And today is a very important topic because we have one of our own experts, and we'll get to, she doesn't like us to introduce her fully, but I would get to briefly introduce her later. So the future of HIV, Elvis, is something which I think we should be able to discuss. It's a pandemic that is very frequent in Africa. And really the topic for today is something I'm coming in here to really learn what the future for HIV and ID in particular, infectious disease, will look like. So this will be a wonderful presentation. I trust her knowledge. And I hope that a lot of our medical doctors, our students will be here to learn a lot on the way forward. But I really hope that the house is going to be a full house, because today is going to be knowledge like no other knowledge. You know that each time we have Boghuma in the house, there is so much to learn.
There's hope for new knowledge.
Yeah.
I'm really curious to learn, especially the part of the topic that talks about the hope for a cure. You know, when I worked at Columbia University Medical Research Center, I was part of the Mosaico study, the HIV vaccine study that ended unprecedentedly because of the lack of efficacy. So I thought that was the last hope for an HIV vaccine, but I know that that was not the last hope. There is hope, and we shall hear that hope today from Professor Boghuma, and we have some our regulars in the house that I just want to check to know how they have been. And let me start with Theodore. Hello, Theodore Semengi. Got you. I saw you. Hello, Theodore. Can we hear your voice? It's always a pleasure to have you, Theodore. Before we get to Theodore, I'm sure he might be trying to unmute. We also have Emmanuel Folak in the house. Hello, Emmanuel.
Hello.
Feel free to unmute yourself. Hi.
Hello.
Yes, Emmanuel, how have you been? And what are your expectations for the session of today?
My ears are itching. And I can tell you, I was just imagining after the COVID vaccine and whatever and so on, and the malaria vaccine, I don't know what I will hear about HIV.
Great. I think you hear a lot. And so without taking much time, because I know Professor Boghuma is always very busy and we always like to start early, so she gives the best of her before any other responsibility comes to take her away from us. So at this point in time, and I know that if we introduce her, we'll just be redundant because she has been a speaker in the house several times and she has always been here to give us really, really deep insights on very important topics. So I think, Muno, if you have any other thing to say about the presenter, I think you can only just ice the cake for us to give it over to Boghuma to get on with her presentation.
Yeah, so I'm not going to be long on this. I will just tell the others in the house who are coming in that Boghuma is an assistant professor at Emory, one of the most prestigious infectious disease and internal medicine hospital in the world. and she has a ton of accolades on her. She did her MD in Qs, which she was my classmate, which I'm honored each time because her time is money. So for her to always honor us and be here, it's a big sacrifice for us, for her to be here. And we are very pleased to really have her here. And we want to let her and thank her for always being behind the town hall, for coming and supporting us. And also having ownership of this town hall initiative because she's been there right from the beginning. Also, she's an expert in HIV. She has a PhD in HIV. She's an internal medicine doctor. She's also an infectious disease physician scientist. Not everybody's a physician scientist. Physician scientists are people who do research and have a PhD, and they want to do translational medicine, take medicine from the lab back into clinic and from clinic into the lab. So I just wanted to make people understand that there's a big difference when all of us sit here, we're physicians, but there are people who are exceptional. She's an exceptional talent. I think I'm saying all of this, those who are in the ministry or in Cameroon, if you know about this, please use her. Her time is precious. Everyone in the US wants to use her, and I hope Cameroon is going to benefit from having someone like her, Elvis. So I'm going to leave it that way. She has a TED Talk. She has a lot going on that you cannot believe it. Boghuma gives an excellent presentation every time she goes. So multiple things. She's presented at the level of the Congress, and many other things that we can talk about. So Elvis, over to you. I'll leave it that way. So only thing I want to say is that Cameroon needs
to... you always want to take that of having your... Yes, Mona, can I hear you?
No, it's okay, I'm done.
Maybe I'm losing you unless it's only from my end. I have bad network here, so
yeah,
maybe
I think it's from
forgive me
end.
if I'm speaking.
Yes, it's from your end. It's okay, I'm done.
Okay, good. No, I wanted to say that you always make us jealous when you make her look like too close to you because she's your classmate. Let me tell you also, when somebody succeeds, everybody wants to be there, right? She's also from my village, right? And she's also a member of the steering committee of Dark Africa. So wow. Just to say that we are also close. Let me take it a little bit from you.
That's good.
Anyway, Boghuma, you're very important and dear to us. We don't want to take much time. We hand over the floor to you.
Thank you so much. It's always a pleasure to be back on the town hall. And do I have permission to share my screen?
Yes, please.
Okay. Okay. Is that visible to everyone?
Excellent.
Okay. So like I was saying, it's always an absolute pleasure for me to be back on the town hall. And today I get the extreme privilege of speaking on a topic that's really in my wheelhouse. And I hope that over the next minutes that I spend with you, I will try to give you an overview of what is the future of HIV treatment and the hope for a cure. I know that Elvis and another person who spoke earlier, I think it was Falefek, they mentioned about vaccines. I would like to say that I would not be covering the topic of the HIV vaccine today, because if I included that, then that would need to be essentially a 2-hour lecture. And it was already pretty challenging to try and cover the scope of things that I hoped to share with you in the 1 hour that I've kind of allocated for this talk. But hopefully you learn something new, and then you get the chance to sort of ask questions and we can have a discussion about what really is the future of HIV treatment and what's in the pipeline where treatment and prevention are concerned, and also what are the research avenues that are working towards a cure for HIV. I have no disclosures. I've structured this talk into 3 core sections. I would briefly give you an overview of HIV globally, and then I would spend some time just taking you through the history of antiretroviral therapy and what are the current options for HIV treatment and prevention. Then I would segue into part 3 of the talk, which would really focus on what's in the pipeline for treatment and prevention. So what can we look forward to in the future? Then I will go to part 4, which would be the search for an HIV cure, and really hopefully give you a gist of what HIV cure research is about and what are the avenues that are being explored to essentially try and definitively cure this viral infection that has been a global pandemic or epidemic now for over 42 years. And then I'll conclude with some key messages, and we'll have a chance for the audience to interact and ask some questions. So as we all know, yesterday was December 1st, and it was also the 35th year that we are marking a World HIV Day. And as where things stand currently, there are still about 39 million people globally living with HIV. And in 2022, we still had 1.3 million new infections, and just over 600,000 people died from HIV-related infections. So although we're in the 42nd year of the HIV pandemic, we still have a lot of work to do. And I think that importantly, because we are on the Cameroon Town Hall, it's important to highlight that 70% of people with HIV live in sub-Saharan Africa. And we still have 10 million people with HIV globally who are not on treatment. There's been a lot of progress in the treatment avenues, with 3 out of 4 people with HIV globally being on antiretroviral therapy. So that is really a lot of progress. However, we continue to fail kids because only 1 in 2 children with HIV currently have access to antiretroviral therapy. And when we focus on the groups that are most impacted and really hone in on sub-Saharan Africa, where Cameroon is located, 77% of new HIV infections globally are happening in women and girls between the ages of 15 and 24 in sub-Saharan Africa. And all of this is, although there's been a lot of progress, is happening in the context of the bilateral donors who fund both HIV treatment, prevention, and diagnostics, kind of, you know, losing some of the fire in their belly in terms of funding for HIV. And non-US funding has actually plummeted by about 57% when you look back at the previous 10 years of HIV funding. And this is definitely concerning, because all of the progress that has been made is because of the funding that has allowed us to get people treatment, to get people diagnosed, and to roll out prevention modalities. Now, when we turn to Cameroon, and these numbers are from the UN/AIDS country report, and so definitely coming from the Ministry of Health in Cameroon, in 2022, there were still close to 10,000 new HIV infections in Cameroon, and it's estimated that there are about 500,000 people with HIV in Cameroon. Cameroon is doing where treatment is concerned, with an estimated 80% of people who have HIV actually being able to access antiretroviral therapy. And of those who are accessing antiretroviral therapy, almost 80% have effectively suppressed HIV viremia, which is also another very important positive metric. However, when you think of prevention and pre-exposure prophylaxis, PrEP is still not widely adopted in Cameroon, and as of 2022, there were only about 4,377 doses of PrEP, or people who had actually been able to access this intervention. And again, much like the global scene, only 39% of children between the ages of 0 to 14 who live with HIV are actually able to access treatment in Cameroon, and definitely an area that needs to improve. That being said, the goals have not changed. The UN/AIDS agenda and the WHO priority all still want to end the HIV epidemic by 2030. And what is the goal of ending the HIV epidemic? The start, or kind of the benchmark that has been highlighted as what they want to target, it means that 95% of people who are living with HIV would be aware of their status, and that 95% of these individuals will be on life-saving antiretroviral treatment. And importantly, they will also have effectively suppressed viral loads. So these are the key milestones. And it's important to highlight that there are countries in sub-Saharan Africa that have already hit these metrics, notably Botswana, Eswatini, Rwanda, and the United Republic of Tanzania and Zimbabwe. So it is achievable, and hopefully if we see funding in the areas that I've already described, we hope that in the coming years, we will hit this metric in Cameroon and in other countries in the sub-region. So moving on to the second part of the talk, focusing on the history of antiretroviral therapy and what current options we have to treat HIV. Since HIV was first identified in the early 1980s, it wasn't until 1987 that the first drug shown to be effective for treating HIV, AZT, was discovered. And as you can see, since that time, we now have not only several drugs, but drugs that are able to inhibit the virus replication at different points in the life cycle of the virus. So when you look at the different targets and the different drugs that have been developed since AZT first came to market, you'd realize that there are over 30 available drug treatments in the span of 36 years that we've had access to antiretroviral therapies that are currently available for treatment of HIV. So going from a disease that was essentially a death sentence to a chronic infection that can be effectively managed with combination therapy, and to the point that people with HIV who are taking their medications and are adherent to these therapies are essentially capable of having exactly the same lifespan as people without HIV. So really tremendous progress. And not only have we been able to have multiple drugs for the treatment of HIV, we have also been able to reduce the pill burden of what people take to treat their HIV. Treatment of HIV is usually a combination of 2 or 3 medications, but we also now have several 1 pill a day options. So 3 or 2 medications combined into a single pill that can be effective to treat the infection. And more recently, we are seeing come into market injectable options that are long-acting, and I'll have a chance to talk a bit more in detail about these injectable options. So just to illustrate the multiple single pill a day options and also the injectable options, and you can imagine that this immediately translates into reduced pill burden, improved adherence for the patient, reduced stigma, and of course, fewer side effects compared to a time where people with HIV were taking up to 20 to 30 pills a day in order to treat their infections. Pre-exposure prophylaxis for HIV came much later than HIV therapies, and PrEP is relatively new. The first pre-exposure prophylaxis medications were authorized in 2012. And what is pre-exposure prophylaxis? These are anti-HIV medications which are taken not for treatment, but rather taken to prevent acquisition of HIV, and are generally given to people who may have a higher risk of HIV acquisition. For example, if you are a sex worker, or people, men who have sex with men, or if you're someone with multiple sexual partners and who doesn't routinely use barrier contraceptive measures, then you will be an ideal candidate for pre-exposure prophylaxis. So from having a 2-drug combination for pre-exposure prophylaxis, we are also now seeing come into market injectable formulations for pre-exposure prophylaxis, which do not require daily administration and can actually be given every 2 months, every other month, as a way of preventing HIV. Additionally, we also have depot formulations of antivirals, as is the case with the vaginal ring, which is a ring that is treated with an antiviral called dapivirine, which can be placed in the vagina and can provide a reduced risk for acquiring HIV, which can last up to a month. While these modalities for prevention are great, I think it's also important to point out that having options doesn't always translate into these options being widely available everywhere. And this map is a map from AIDS Info that's available on the UN AIDS website, which shows you the global coverage of these pre-exposure prophylaxis modalities that I've mentioned to you. And access to pre-exposure prophylaxis still remains quite low. And when you think about the initial slide that I showed when I was talking about the global state of HIV, we're still seeing 1.3 million infections, new infections every year. And when you consider that injectable pre-exposure prophylaxis and oral pills, antiretrovirals for pre-exposure prophylaxis are up to 98% effective in preventing HIV, this really is a missed opportunity for us to prevent new infections from occurring. And so there's a great need to increase PrEP coverage in Africa. Moving on to the third part, this is where I would really get into the details of what are the new drugs, what's in the pipeline. We now have treatment, we have people accessing these treatments. Is there room for improvement in the treatment of HIV? And the first group of medications that I wanted to talk to you about are the long-acting drugs that are currently available or are being looked at and studied in advanced clinical trials for the treatment of HIV. These are medications that have a longer half-life, and as such, it allows for us to have an increased dosing interval for these medications. So instead of having to take a daily pill to treat your HIV, we are beginning to start moving towards formulations that can be injected once every month or once every other month, or even drugs that can be administered every 6 months, and with the view of even having formulations that could be administered once a year. So this is, again, the picture of the HIV life cycle, which you would see several times throughout this talk, because it's important to understand the HIV life cycle to understand where these different medications work in their ability to block HIV replication and essentially control the disease. So looking at point number one as the start of the HIV life cycle, HIV prefers or has a preference for attacking white blood cells which carry the CD4 receptor. So what T cells with the CD4 positive T cells. And HIV uses as its primary receptor the CD4 receptor that is present on the surface of white blood cells, and also uses a co-receptor known as the CCR5 receptor or the CXCR4 receptor, which is another co-receptor that HIV can use. When the virus attaches to the cell, the envelope proteins of the virus allow it to fuse with the surface of the cell so that the genetic material of the virus is released into the cell. Once it's released into the cell, the RNA of the virus has to be transformed through a process called reverse transcription into DNA, which can then make it into the nucleus. So you have medications that are able to block HIV from attaching to its receptor or to its co-receptor. You have medications that are able to prevent HIV from fusing its envelope with the cell membrane and allowing entry of the viral genome into the cell. And you also have medications that can inhibit replication of the virus by inhibiting reverse transcriptase. And you have medications that impact the ability of the RNA that has been transformed into DNA from getting into the cell's nucleus. Once you have reverse transcription of the viral RNA into DNA, that's then transported into the nucleus, and that DNA inserts itself into the human genome. So essentially, imagine that this is a piece of your genetic material in your white blood cells. What HIV does is it cuts a point in your own genetic material and inserts its own genetic material, And by so doing, essentially tells the cells, make more of me. And then the cell is able to make virus proteins that then assemble to make new virus. And then that new virus makes new baby viruses that become packaged to look like the original virus that infected the cell and gets released from the cell to go on and infect other cells. So you have medications that can impact on the integration of the virus into the DNA, and you have medications that also disrupt the packaging of the new viruses and their release from the cell. So these are all the points at which different antiretroviral drugs have their action. When it comes to long-acting medication, you have the drug lenacapavir, which I would go into great detail to talk about because a very interesting molecule that's coming through the pike. And lenacapavir has the advantage that it is what we call a capsid inhibitor. It inhibits or destabilizes the capsid of the virus, which is the part of the virus that surrounds the virus's genetic material. And by so doing, affects reverse transcription, affects transportation of the virus DNA into the cell nucleus, also affects assembly of the new variants and their release from the cell. So lenacapavir is able to inhibit the virus at 4 different steps in its replication cycle. The other long-acting medications are a class of medications that belong to what we call nucleoside reverse transcriptase inhibitors, and those are rilpivirine and islatravir, and they disrupt that reverse transcription step, which is important for converting the virus RNA into DNA. And then we have cabotegravir, which is an integrase inhibitor, which inhibits the step of the virus being able to integrate into the host genome. So the first drug is islatravir that I'm going to talk about. This is one of the novel reverse transcriptase inhibitors. It's not yet FDA approved. It has a half-life of about 128 hours and can be dosed once a week. Now, the initial clinical trials that started looking at the use of islatravir for treatment of HIV were initially halted in 2021 because in some of the early phase 1 and phase 2 studies, they noted that individuals who received islatravir had an unexpected decrease in CD4 T cell count and in their white cell counts. And these decrease in white blood cell counts was thought to be related to the dose of the medication that was being tested. It was a 2 milligram dose that was being tested in these studies. So they halted the studies because obviously when you're treating HIV, which is a virus that attacks your T cells, you don't want a medication that impacts or reduces the T cells, because the goal of treating HIV is to make sure you're restoring the T cells and restoring the immune system. So they had to figure out why islatravir was dropping the T cell count. Fortunately, these studies have now been resumed, and they're looking at lower doses of islatravir, which have not been associated with that adverse effect of impacting CD4 T cell counts and white blood cell counts. And there are advanced phase 3 studies, which are currently looking at islatravir in combination with another antiretroviral called doravirine, which is already licensed, as treatment for HIV. And they're also looking at switching people from existing 1 pill a day options to combination therapies that contain islatravir. There are phase 2 studies looking at islatravir in combination with lenacapavir, and they are studying lower doses of the medication to see or find doses that are safe where T cell counts and white blood cell counts are involved. And I think it's important to mention that so far in the studies that have looked at islatravir, there has not been any evidence indicating that it interacts with existing or commonly used antiretroviral drugs. So that is reassuring because it can be combined with these drugs for treatment. And it's also currently being studied as a way of, as a drug for pre-exposure prophylaxis. The second medication is lenacapavir. Remember, this is the super potent antiretroviral that is able to inhibit the virus replication at 4 different points in its life cycle. And it also, in addition to that superpower, as I would call it, has a half-life that is as long as 11 weeks and can be administered subcutaneously. This extremely long half-life gives lenacapavir the ability to be dosed every 6 months. And it's currently FDA approved, but only FDA approved for treatment of people who have failed the therapies that we have in the clinic. And there was this study that was published in the New England Journal of Medicine in 2021, which was the Capella study that demonstrated the effectiveness of lenacapavir in treating people with extensive drug resistance to existing HIV therapies. So these are people who were maybe diagnosed in the 90s or in the early 2000s, who have had issues with adherence and have developed drug resistance to multiple drugs and are on optimized oral regimen, but still having detectable virus. So they identified 72 of these individuals and gave them the best optimized oral therapy and added on that oral therapy lenacapavir in an attempt to get their viral load to undetectable levels. And in these 2 studies that were published as the Capella study, all these individuals, about greater than 80% of individuals who received the lenacapavir were able to have undetectable viral loads at 26 weeks. So it's currently approved for salvage therapy in people who are failing standard therapies that we have. But there's a lot of excitement and studies going on to use lenacapavir as first-line treatment for HIV. And there are currently studies that are studying lenacapavir in combination with existing antiretrovirals, such as tenofovir or emtricitabine. And they're also studying it as switch therapy for people who are already taking other oral antiretroviral therapies. They're studying the combination of lenacapavir with islatravir to see whether you could switch these individuals to combinations of drugs that have a longer half-life and can be dosed maybe every 2 months or every 3 months and not require a daily dosing. It's also being studied for use as pre-exposure prophylaxis and also being explored in combination with monoclonal antibodies, which I would talk about later in the course of this talk. The third and final 2 drugs in the long-acting medications are cabotegravir, which is an integrase inhibitor, has been FDA approved, and rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. And they have been formulated as a combination where you can give them as 2 separate injections at the same time for treatment of HIV. The combination is called Cabenuva, and it's an extended intramuscular injection formulation for treatment of HIV, which can be given once a month or every other month. And in the studies that led to the approval of rilpivirine cabotegravir for treatment, they compared it to existing 1 pill a day oral regimens and found that cabotegravir rilpivirine was non-inferior, meaning it worked just as well. Currently, there are ongoing studies that are looking at the co-formulation of cabotegravir with neutralizing antibodies, and cabotegravir monotherapy has also been shown to be effective for pre-exposure prophylaxis. They're doing secondary assessments to see whether this medication is safe for use in pregnancy so that it can be accessed by the population of pregnant women, because it's currently not approved for that population. The next thing I wanted to talk about is alternative delivery methods. So far we've talked about pill formulations, which is what people are immediately familiar with, and injectable formulations. But because these drugs are long-acting, that also allows for us to study alternative delivery methods for these medications. So the first alternative delivery method I want to talk about is the subdermal implant. The subdermal implant is the size of about a 50-franc coin. And this is usually made with a material such as silicone and can be implanted just in the subdermis. This material is treated with the antiviral and then implant it underneath the skin so that it can progressively, slowly release the drug over time. As you can imagine, if you're able to formulate an antiviral drug as a subdermal implant, it will require less frequent dosing because it's a slow release formulation. And there's also the ability to take out the implant in case a patient develops an adverse reaction to the medication. The implants are very discreet. I told you that it's the size of a 50-franc coin it's not visible. So you wouldn't know someone had an implant delivering antiretroviral therapy unless you palpated their subdermis and felt the implant. Now, what are some of the downsides of this alternative delivery method that's being studied? It requires insertion under sterile conditions by trained staff. And in order for it to be considered for treatment application, you have to find drugs that are compatible to be co-formulated together on an implant that can be inserted subdermally. There are currently ongoing phase 1 studies that have looked at islatravir implants for pre-exposure prophylaxis. And these studies were very exciting because this implant showed the potential to be administered just once a year. So imagine being able to have an intradermal implant with islatravir that is essentially pre-exposure prophylaxis that lasts you an entire year and doesn't require you to either take an injection or take an oral daily medication. The second delivery method that is also kind of being looked at in this space are the intravaginal inserts. I've already mentioned the dapivirine ring. These are, again, silicone-based inserts that are treated with the antiviral modality and can be inserted into the vagina so that they release the antiviral medication locally in the vagina with very little systemic absorption into the bloodstream. What this means is that because they're acting locally, they have the ability to then neutralize any virus that is in that area and reduce the transmission of HIV. What are some of the advantages of vaginal inserts? The woman has control of inserting her vaginal insert. So it's patient initiated, right? It's person initiated, and that control and freedom allows for convenience. It lasts, or its effects can last up to a month. So you can keep it in place for a month or longer. It's discreet, it's not perceived by the partner, and it reduces HIV transmission risk. Although I have to highlight that the currently available intravaginal insert, dapivirine, which is approved by the WHO, only reduces HIV acquisition by 30 to 50%. So it's a less effective modality than, say, oral PrEP or injectable PrEP, which is 98% effective. What are some of the downsides? It can cause some local irritation, and it does not prevent other sexually transmissible infections such as gonorrhea, chlamydia, syphilis, or herpes. And also, it doesn't prevent pregnancy. And they're also currently looking at co-formulations of dapivirine with contraceptives to prevent pregnancy. So this is an exciting space to watch. The next treatment modality is the microneedle patch. This is very innovative and very exciting, particularly coming into the HIV field. And what is the microneedle patch? Essentially, it's like a piece of plaster that has embedded into it very tiny microneedles, as shown on this slide. So you can see the little indentations on that plastic base are microneedles that can be loaded with medication. And then when you stick the patch on the skin, those little needles inject the medication into the subdermis, and that is then absorbed into the bloodstream, delivering the medication. It is painless and can be self-administered. And so you can imagine that because it's non-invasive, painless delivery that can be self-administered, it brings with it enhanced user convenience. It's also incredibly discreet and has the potential to also deliver medications with controlled release over time. So it might be a microneedle patch that only has to be placed once a week or once a month or once every 6 months, depending on the way in which the delivery is formulated. Some of the downsides are that there can be some skin irritation at the site of application. And also because the needles are so small, there's only so much drug that can be loaded into those microneedles. So imagine some of the antiretroviral drugs that we prescribe. Let me take, for example, dolutegravir needs a 50 milligram dose. Islatravir that I have mentioned before is currently being evaluated at a 0.5 milligram dose. So islatravir is more likely and easier to be co-formulated or formulated into a microneedle patch compared to a drug whose dosing is much higher. So that would kind of limit which drugs can be delivered through this mode of delivery. And also, if they're not properly stored, there can be inconsistencies in drug delivery, and they're also incredibly costly to manufacture. So there would be some barriers to scalability and who can access these options when they ultimately come to market. They're in early phases of development, and I'm actually really proud to say that there's actually one of my colleagues in our lab working in collaboration with Georgia Tech University engineers developing a microneedle patch for the delivery of some of the antiretroviral drugs that I've already talked about so far. And the final mode of delivery, I've already kind of talked about and alluded to, is the one that is most advanced in its deployment in the clinic. Those are the long-acting extended release injectable delivery antiretrovirals. And they have reduced dosing frequency, privacy and convenience, reduce stigma, and they improve adherence. And one of the most important things when it comes to antiretroviral adherence is always reminding people that improved adherence also means reducing drug resistance, because if people are taking their medications as they're supposed to, they are at a lower risk of selecting for drug resistance. What are some of the downsides? They can be injection site reactions. We are actively rolling out these injectables in my clinic currently, and we don't see a lot of people discontinue because of these site reactions. So these thankfully are rare. Because they are depot intramuscular formulations, if a patient develops an adverse effect, you can't discontinue the medication, because once you've administered the dose, that medication with a long half-life would last in the system for at least a month. So the person would experience those side effects until the medication has been washed out of the system. So that can be a downside. There are limited drug options currently with this modality, because we just have cabotegravir and rilpivirine that have been authorized, and it's more expensive. The current antiretroviral drugs that we have, if you're not covered by insurance, if it's a pill and one pill a day, in the US would cost about $3,500 a month for your monthly supply. But cabotegravir rilpivirine costs $6,500 a month. So definitely more expensive than the oral options. Additionally, an important downside is that cabotegravir and rilpivirine do not have a spectrum in treating hepatitis B virus. About 10 to 20%, depending on which country you're looking at, of people with HIV also have hepatitis B co-infection. And a lot of the one pill a day options that we have contain tenofovir and lamivudine, which are medications that are effective against hepatitis B. So if you have a patient on an oral drug that contains tenofovir and lamivudine, you are essentially not only treating their HIV, if they have an HBV co-infection, you're treating two infections at the same time. However, with the injectables, you will treat their HIV, but they will still need to have an oral treatment to make sure that their HBV is treated. So the next group of medications, and I put this separately from the antiretroviral drugs because these are not really synthetic medications. These are called biologic agents, are the broadly neutralizing antibodies. So what are broadly neutralizing antibodies? These are antibodies that are isolated from individuals who mount a very strong response to HIV and are able to produce antibodies to HIV that have the ability to broadly neutralize various strains of the virus. These individuals are rare. They usually have had HIV for a long time, but they have identified these antibodies from select individuals that have the ability to neutralize broad strains of the HIV virus. So broadly neutralizing antibodies are currently being studied for HIV vaccines, but also being studied for pre-exposure prophylaxis, as well as part of combination therapy with antiretroviral treatments for antiretroviral drugs for treatment. And what is the advantage of broadly neutralizing antibodies? Like I mentioned, they're isolated from people with HIV. So they're not considered synthetic, they're natural, they're biologic medications, which may increase their acceptability for some people who don't want to take synthetically produced drugs. They also have a very long half-life. And so if administered, their effects can last for several weeks to months, which allows them to be dosed in a manner that requires less frequent dosing for treatment or for prevention. So like I mentioned, broadly neutralizing antibodies have half-lives of several weeks. They require an infusion for their administration, and there are currently none which have been approved as part of treatment or prevention of HIV. However, there are several that are actually being studied. And there are two key studies that were published in the New England Journal of Medicine that looked at broadly neutralizing antibodies, combination of two broadly neutralizing antibodies as pre-exposure prophylaxis for HIV in men and transgender people in the US and in Europe, and also as pre-exposure prophylaxis for young women and girls in Africa. And they compared the efficacy of these medications in reducing HIV acquisition to placebo. Unfortunately, these studies did not show an effect. And it is because, again, in order for broadly neutralizing antibodies to be effective, they have to match the strain of circulating virus. And one of the things that HIV does is that it's able to change itself so much that there are so many different variants of the virus. And if you don't have a good match between the circulating virus that the patient is exposed to and the neutralizing antibody that they're taking for pre-exposure prophylaxis, of course, that modality would not work. So in this study, although it was a negative study, it still allowed us to understand the importance of matching the neutralizing antibody that you use for PrEP to the virus that is circulating. There are currently ongoing studies looking at the combination of broadly neutralizing antibodies with lenacapavir and seeing if this combination can be given every 6 months as treatment for HIV. It's reassuring to note that these are very safe in the studies that have looked at them. And there are currently multiple dose finding studies to try and figure out what is the right dose, what is the right dosing frequency to use for treatment and for prevention. And like with the other modalities, there's always pros and cons, right? I've already mentioned some of the pros, which are the increased interval dosing, the enhanced adherence, because people don't have to think about taking a medication every day, and the enhanced acceptability. They can have an activity of up to 6 months. So imagine, again, being able to go for 6 months without having to worry about taking a medication to treat HIV. They need to match the virus. That is the biggest issue that we deal with. And there's always a risk that the virus that's circulating, even if it's well matched to the neutralizing antibody, will select for resistance to that antibody over time. They require infusion. So you have to take time out of your day, go to a clinic and get an infusion that literally takes about 15 to 30 minutes to administer. and they're quite expensive to manufacture. So that may also be a barrier that limits access. Worth mentioning, I thought, other modalities that are interesting and also patient-controlled and can, enhance the ability for us to offer different options for people to prevent HIV. We are currently studying, or they're currently in studies currently looking at microbicide douches. These are douches that can be administered on mucosal surfaces that contain either an antiviral or an antiseptic agent to essentially, again, deliver a medication or an antiseptic at the mucosal level to prevent entry of the virus. And we also have gel formulations of different antivirals. So a gel that can be applied to a mucosal surface to reduce transmission of the virus at that surface, as well as rectal and vaginal inserts that are treated with antivirals, again, for delivery at the mucosal surface. So lots in the pipeline where pre-exposure prophylaxis is concerned. And just to give you an idea of the buffet of options and things that are in the pipeline, these are patches, mucosal gels, mucosal vaginal rings, implants. These are what we have in the pipeline as of October 2022 in preclinical all the way through late phase studies. So actively, these are being looked at, and in the next five years or so, some of these should start coming to market. So to wrap up this section of the talk, we've gone from the early 90s where people with HIV were having to take 20 to 30 pills a day to the mid-2000s where we had 1 pill a day options for people to be able to control their HIV. Now to the 2020s where we have injections that can be administered once a month or once every other month. We also now have in the pipeline several customizable options that will be adapted to individual patient needs and preferences. And I always like to highlight in this talk, because when some of these modalities start coming into lower income countries, there's always the misinformation of they're coming to experiment on us with these new treatments. It's important to highlight that the delivery methods that I've talked about in this talk are not new. They're new to HIV. They're bringing them to HIV treatment, but we already use subdermal implants for contraception in women. The Norplant, it's available in Cameroon. So that's only being brought into HIV to allow people living with HIV to have more options. We already use depot formulations for treatment of osteoporosis and long-acting formulations of medications for treatment of different psychiatric illnesses. So I think that it is an added advantage to see some of these modalities come into the HIV treatment and prevention arena to allow more options for us to fight this global epidemic. The fourth and final section of the talk is the search for an HIV cure. And this is by no means an exhaustive talk on HIV cure, because that in itself would require several talks in basically a series. But I'm hoping that you would be able to get a general understanding of what we are looking at or talking about when we are talking about HIV cure research, and also get an idea of what's happening in the cure arena. I already started this talk by telling you that by the end of the hour, you would have to become somewhat familiar with the HIV life cycle, because to understand why it's difficult to cure HIV, you have to understand how HIV replicates and how HIV leads to an infection. So before we actually go into the different cure modalities, I thought it was important to remind the audience of what are the barriers to causing HIV? Why is it to curing HIV? Why is it so difficult to cure an HIV? 42 years and counting. We have treatments, but we cannot cure HIV. What is the barrier? Firstly, HIV is a virus that in replicating itself makes a lot of mistakes, in the sense that the enzyme that is able to replicate the HIV genome is not very good at correcting the errors it makes as it copies the viral genetic material to allow the virus to make new viruses. So which means that the daughter viruses that are produced by the original virus that got into the cell are never identical to the parent virus. And this leads to basically what we call a quasi-species. So viruses that are slightly different from each other, but are all HIV viruses. And this has led to different HIV strains. So it has a high mutation rate that leads to multiple strains of the virus. So it makes it difficult to develop a single treatment or vaccine that would effectively treat and prevent all of these different strains. So that's the first thing that is a barrier to a cure. The second thing, as I mentioned before, the cells that HIV prefers to infect are CD4 positive T cells. And these are cells that can either exist in an active state or can also be quiescent and go into latency. Now, a cell is only producing HIV virus when it is activated and is actively allowing the virus to use its machinery to make more virus. T cells that go into latency or are asleep are not producing the virus. And as such, the virus is able to basically also go to sleep with the cells. And this latency develops a reservoir in the body of the person who has HIV, because you can treat the person with HIV and eliminate all circulating virus, but the virus that is sleeping in latent cells, which can live for many years, the moment you stop that HIV treatment, some of these cells wake up and promptly start making new virus. So latency is another big barrier to curing HIV. The third piece, remember when I was going through the steps of the HIV life cycle, I talked about the viral RNA being converted into cDNA, and that DNA going into the nucleus and becoming integrated into the host genome as a provirus. So essentially, the virus inserts itself into the host genome. How can you purge out a virus that is essentially has become part of the cell? It makes it then challenging to eradicate the virus completely without damaging the host cells. And I already talked a little bit about reservoirs, but there are also sanctuary sites, what we call sanctuary sites, like the central nervous system is considered a sanctuary site. These are sites in the body where antiretroviral drugs may not necessarily penetrate to the same extent as other tissues. And these are sites that allow the virus to hide. And it makes it difficult to purge out because they are these sites that we cannot effectively target with our current treatments. And lastly, HIV can infect subsets of the immune cells, which are long-lived. So these are cells that can last and live for years, 40 years in some instances. So if you have cells that are able to be long-lived cells and can be infected for that long a time, then it's at any point when you stop HIV treatment, those cells can replenish the virus that you had already eliminated by making new virus. So these are the challenges that we're dealing with when we think about HIV cure. However, we have a few rare instances in which HIV has been cured. To date, there are 5 people who have been cured of HIV. There are 3 instances of men who have been cured with HIV through getting stem cell transplants that were indicated because they had cancer. And why they achieved the cure, remember when I was talking about the HIV life cycle, I mentioned that HIV uses a primary receptor to attach to the cell, which is the CD4 receptor, but it also uses a co-receptor. It has 2 options for the co-receptor, either a CCR5 receptor or a CXCR4 receptor. The viruses that establish an infection in an individual can either be viruses that like to use the CCR5 receptor, or they can be viruses that like to use the CXCR4 receptor, or they can be viruses that are capable of using either co-receptor. In these individuals, all of these individuals were infected with viruses that like to use the CCR5 receptor. And we have people in the general population, about 3% of people in the general population, the Caucasian population, lower rates in the Black and non-Caucasian populations that are homozygous, have a homozygous deletion for this CCR5 receptor. Taking you back to your genetic classes, homozygous means they don't have two alleles expressing that allow them to express this receptor. So their cells do not have the CCR5 receptor. In the 3 instances of cure, these people had bone marrow donor or stem cell donor matches from individuals who were homozygous for the CCR5 delta 32 mutation. So they got stem cells from individuals who don't express CCR5, and these individuals had chemotherapy to basically wipe out their own white blood cells, and then received stem cell transplantation from these donors carrying CCR5 delta 32 mutation. So which means that when their white cells were replenished and restored with the donor cells, they had now cells that no longer express CCR5 receptor, and essentially the virus couldn't infect new cells and reestablish an infection. And over time, looking for the virus in the system, the viruses that they had in the system ultimately died, and these people have cleared all HIV from their systems and even converted their antibody tests to a negative HIV antibody test and have effectively been cured from HIV. So those are the 3 instances of cure with a CCR5 delta 32 homozygous donor. The 4th instance of cure, and the only woman who has been cured through stem cell transplantation, was cured using a different type of transplant. This is also someone with HIV for many years on antiretroviral therapy who developed a cancer for which they needed a stem cell transplant. In this instance, because this person was mixed race, and because it's oftentimes very challenging to find a donor that matches, a stem cell donor that matches people who are Black or non-white ethnicities, because in the donor banks, there are not enough donors who are of non-white ethnicity. They used what we call stem cells that are derived from umbilical, what they call it, they use stem cells that were derived from cord stem cells. And the thing with cord-derived stem cells is that you don't have to have a perfect match for a cord-derived stem cell to be given to someone. So they were able to, it allows for a broader pool of donors because a partial match can allow for the stem cells to be used for transplantation. The stem cells that were used, although they were derived from cord stem cells, they were also CCR5 delta, also had a CCR5 delta 32 mutation. So again, the patient got chemotherapy and pre-treatment to wipe out their own white cells. Then they received the stem cell transplantation, and then over time eliminated the virus from their system, because when their white blood cells were restored, the restored white blood cells no longer carried the co-receptor that HIV needed to be able to attach and infect the cell, and that individual over time has effectively been cured of HIV. So when we look for the virus in these persons, we cannot find the virus, and they have converted their serologies to HIV seronegative. There's one instance of cure called the Esperanza patient, which is a patient out of Argentina. This individual did not receive stem cell transplantation. They spontaneously cleared the virus without receiving any therapy. And in this instance, it's thought that it's their immune system that was able to allow the patient to clear the virus over time. So it's very interesting to study and understand why this individual's immune system was able to clear the virus over time, and what we can learn from that and apply to the different strategies as we approach and look for an HIV cure that can be used for everyone. Now, I've mentioned to you 4 instances of cure through stem cell transplantation. A stem cell transplantation cost about 50 million CFA if you were to convert the cost of stem cell transplantation. And so you can see that that is not a treatment that is feasible to use for the 39 million people who are currently living with HIV. And I'm glad that we have an oncologist on the call, because again, stem cell transplantation comes with a very high risk of death in itself. It's a highly risky procedure that can carry a mortality of up to 25%. So while it's good for these individuals that they were effectively cured, this is far from a cure that can be considered a cure that we can use for everybody living with HIV. Besides the cures that I have mentioned to you, there are also important instances that we can learn from to understand how the immune system can better control the virus. There are some individuals who have been able to use their own immune system to effectively control their viremia to very low levels or to undetectable levels of antiretroviral therapy. And I think that it's important to mention these instances. One of them is something we call the Visconti cohort, which is a cohort of individuals in France who are individuals who were started on antiretroviral therapy in the acute phase of their HIV infection. So basically within 10 days of acquiring HIV, they were given antiretroviral therapy. What that very early antiretroviral therapy does is it reduces the degree to which the virus was able to establish a robust reservoir. And over time, these individuals have been taken off antiretroviral therapy, and their own immune system is continuing to be able to maintain the virus below detectable levels. So that is a cohort that's very interesting, because there's some data that has accrued through the years that indicate that if you treat people very early on, you reduce the reservoir and improve the immune responses against HIV in a way in which the immune system can then be able to effectively control HIV infection. It's a small cohort, but it's a cohort that we've learned a lot from. There's a very small subset of people with HIVs, about 0.5% of people with HIV, known as elite controllers. These are individuals who, without any antiretroviral therapy, have immune responses that allow them to control the virus and suppress it below detectable levels. And there are many mechanisms for it's not one single immune mechanism of control for all elite controllers. Some of them are able to have cytotoxic T cells that can effectively control the virus. Some of them mount robust antibody responses that can control the virus. Some of them have natural killer cells that are able to control the virus. So we are studying these different mechanisms as ways of which to understand what elements or what characteristics of an immune response can allow individuals to control the virus without medication. And the third instance is, I'm sure maybe some of you in the audience a few years ago heard the story of the Mississippi baby, who is a baby who was born to an HIV-infected mother, and ART was initiated basically within the few hours following birth. And that early initiation, again, much like with the people in the Visconti cohort, that child, after antiretroviral therapy was discontinued, was able to effectively control the viral load for 27 months. And initially in the early months of that child having an undetectable viral load, there was a lot of excitement that this was another case of cure. Unfortunately, at 27 months of age, the virus rebounded. But again, that instance allowed us to understand that in pediatric HIV, where the immune system is very different, early treatment can also induce better immune responses to the residual virus that is left, and these individuals can control the virus with their immune systems off antiretroviral therapy for months. So when we talk about the HIV cure, I think it's important to define what cure means. Are we talking about eradicating the virus completely, or are we talking about remission? So being able to have one's immune system control the virus without the need for drugs. So these are the two different types of cure. A sterilizing cure will mean that you have purged all the virus from a person's system. That will be the cure examples that I showed you, the 5 different cures examples that I showed you, 4 from stem transplant and the 5th from a mechanism that we're still trying to understand. So complete elimination of all replication competent HIV in a person's system. The functional cure is more remission. I've given you instances of people who are treated very early and then subsequently their immune system takes over and is able to control the viremia without them needing additional treatment. So we're looking both at sterilizing cures and we're looking at functional cures. So now going to the different approaches, there are 4 main approaches to cure, and I would go over each one, not in great detail, but just to give you a flavor of what each of those cure approaches actually means. There's what we call shock and kill. There's what we call gene editing to target the latent reservoir. There's another strategy that we call lock and block. And the 4th group of strategies is immunotherapies and neutralizing antibodies, CAR T-cell therapy, and therapeutic vaccines, again, improving the immune system's ability to control the virus without the need for antiretroviral therapy. This figure is noisy, but just kind of highlights the different strategies that I have listed here. So starting with shock and kill. What is shock and kill? Taking you back to the HIV life cycle. Remember, I mentioned to you HIV RNA transforms, converts to DNA, becomes integrated into the host genome in cells that can go to sleep. And when these cells are asleep, they're not making virus and they're allowing the virus to hide. Shock and kill uses medications that we call latency reversing agents. These medications essentially wake these cells up from their resting state into the active state so that they can go back to producing HIV virus, and then we can attack the virus producing cells with antiretroviral therapy to allow clearance of the virus over time. The problem with latency reversing agents is that although they have been shown to awaken cells, resting T cells that form the viral reservoir, we have not fully characterized all the different types of cells that can harbor the HIV reservoir. Also, the latency reversal agents do not awaken all of the reservoir. They may awaken 20% of the reservoir. So we're still trying to understand what combination, what dosing frequency of different latency reversal agents we need in order to effectively purge out that reservoir so that we can kill all infected cells that are harboring HIV. Additionally, we don't have great scalable ways of measuring the viral reservoir. There are assays that we use in the lab to quantify this reservoir, but these assays are not scalable. We don't yet have an assay where if you had a patient on a combination of latency reversal agents plus ART to try to cure them, that you could go to and give a blood test for it to be easily done to quantify the reservoir. So These are the challenges that shock and kill currently faces, but it is a strategy that can be used as an approach. It's one of the approaches that is being looked at as a cure for HIV. The second strategies are more a group of strategies, ways of gene editing for HIV cure. And this figure kind of separates the different strategies into two. There you have CAR T therapy, and I'm sure some of you have heard of CAR T therapy. CAR just simply means chimeric antigen receptor. And what is that therapy? You take someone with HIV and they undergo a simple process that can be done in the clinic. Again, we have an oncologist on the call. They undergo what we call leukapheresis. What is leukapheresis? It's essentially taking a procedure that allows us to collect just the white blood cells from a patient and isolate their CD4 T cells from the white blood cells that are collected. And their red blood cells are given back to the patient. So they're not losing blood when they do leukapheresis. We're just isolating their white blood cells. The T cells that are isolated from these patients are then modified to express what we call a chimeric antigen receptor. And what those chimeric antigen receptors are, they are genetically engineered receptors that can recognize a variety of proteins. In the case of cancer, they recognize different cancer receptors, and then if they're reinfused into the patient, can attack the cancer and treat the cancer. In the case of HIV, there are chimeric antigen receptors that are able to recognize the HIV envelope protein. And if you expand these cells and give them back to the patient as an infusion, these T cells that have the ability to recognize HIV infected cells can then target the HIV cells and destroy them as part of an HIV cure. So that's how we are looking at CAR T therapy as a way of treating HIV. The second options for gene editing are ex vivo gene editing techniques. It's kind of similar to CAR T, but we're doing different things with the cell. So again, you do a leukapheresis, isolate PBMCs, white blood cells from an individual, take those white blood cells, isolate their cells, and you use zinc finger nucleases, which are another way of editing the genetic material, and essentially engineer those cells so that you go in and cut out the genes that allow the cells to express the CCR5 co-receptor. And then these modified CCR5 negative white blood cells are reinfused to the patient so that the patient now has circulating white blood cells that no longer contain the receptor that HIV needs in order to cause an infection. So over time, when the virus looks for cells that carry its co-receptor and doesn't find them, the virus would not be able to infect new cells, and then that would achieve a cure. There are in vivo gene therapy options, and this just kind of summarizes what the in vivo gene therapy options are. We can use viral vectors to introduce, usually they're adenovirus-associated viral vectors that allow us to introduce DNA into the patient, or introduce DNA that can then lead to production of neutralizing antibodies, which are engineered to basically induce the production of neutralizing antibodies that can neutralize HIV and serve as a cure. There are studies that are looking at directly using adenovirus vectors to deliver CRISPR targeted strategies. CRISPR, again, is gene editing. So you're essentially delivering gene therapies that can actually go into the cells, edit out the HIV virus so that essentially excising that virus out of the person's genetic material. The problem is that HIV doesn't integrate or go into a cell and go to exactly the same part in your genetic material to insert itself. It does that stochastically. It can insert itself at different points in the genome. And these points are not predictable. and they're also not the same across the different strains of the virus. So that makes it challenging to target gene editing to go in and excise all of the HIV that is hiding in different cells that harbor the virus in your genome. And then the last bit is mRNA containing strategies, which can be mRNAs that can be delivered to induce production of neutralizing antibodies, again, to neutralize circulating virus. The third strategy is lock and block. Remember, I talked to you about shock and kill, which use latency reactivation agent. With lock and block, we're using latency promoting agents. So remember, those cells that are already asleep and have HIV hiding in them, latency promoting agents put them into an even deeper sleep so that they are more difficult to reactivate. So essentially, you are trying to basically lock HIV in a state of permanent sleep so that there's not a constant source for HIV to come from its latent reservoir and reestablish an infection when you stop antiretroviral therapy. So the goal with block and lock is that you essentially put the HIV reservoir into a state of permanent sleep, and then you can take away antiretroviral therapy with the hope that the locking the HIV into cells that are in a super latent state would mean that the cells would not reactivate to start producing virus and lead to detectable viremia. With lock and block, that would mean that the patient will still need to go to the hospital at a certain frequency for us to continue monitoring whether their viremia has become detectable. So that is one of the considerations. And then the final approach is immunotherapies, and there are a variety of them, which include some of the ones that I've already mentioned. We've talked about CAR T cells, we've talked about gene therapy, we've talked about broadly neutralizing antibodies, and also there are immunomodulatory drugs that can influence different aspects of HIV latency and HIV reactivation that we can use as ways of exploring treatment. In these instances, you have someone who has HIV, is put on antiretroviral therapy, suppresses their viral load, and then you would give them a form of immunotherapy that would allow their immune system to then be able to control the virus once they're taken off antiretroviral therapy. Like with lock and block, it also requires monitoring over time. And it's important to note that immunomodulatory agents, depending on the ones that you're looking at, also carry adverse effects that in themselves can be limiting to deliver some of these therapies. So what are the HIV cure strategies appropriate for Africa? We've talked about a lot of strategies, and a lot of these, I'm sure to the audience, seem very involved. None of this sounds simple. It sounds like a lot of work to actually try to cure people from HIV. The good news is that Africa is not being left behind where cure research is involved, and there are actually a lot of cure studies that are ongoing in Africa. We have studies that are looking at combinations of neutralizing antibodies with latency reversal agents, and that are set to release results as early as next year. And we have treatment intensification studies that are alongside with neutralizing antibodies also going on in pediatric centers across Africa, mainly in Southern Africa. And there are a series of studies that have looked at neutralizing antibodies for cure that have already been completed again and have recruited patients primarily in Southern African countries. When you think about what HIV cure strategies are appropriate for Africa, I don't think it's my place to pick one or the other. What I hope that I would stimulate is actually things I think are important to consider when we think about strategies that are appropriate for HIV cure. How will the African population perceive a functional cure versus a sterilizing cure? Like if you have someone living with HIV and you tell them, well, I could cure you with a functional cure, but you still need to come see me in clinic every month to check your viral load and make sure that the virus is still asleep will that person perceive it as a cure? Or will there be a preference for a sterilizing cure where they're absolutely sure that they no longer have HIV? Will people in Africa accept strategies like lock and block, where you still have the virus in you, but it's just deeply asleep? Imagine discordant couples. If you met someone and you said, oh, I have HIV, but don't worry, I cannot pass it on. I'm on this lock and block therapy, which means that the HIV in my system is asleep. Is that something that would be acceptable? Is that something that would really be perceived as a cure? Which of these strategies are logistically feasible in Africa? All of these therapies I've mentioned to you are extremely costly. There's a cost that is associated with them. There is also the need for very advanced technologies, ability to do leukapheresis, ability to genetically engineer cells and reinfuse them into individuals. That requires monitoring, that requires the expertise of people capable of delivering these treatments, and it comes at a cost. I already told you that the donors that support a lot of the HIV diagnosis and treatment, that money is down 57%. So that would be an important consideration when thinking about how to roll out cure strategies if they ever come to market to a broad population like the 70% of people living with HIV globally who find themselves in sub-Saharan Africa. And I think it's also important and not negligible to talk about how the misinformation that has come through from the COVID vaccine impacts the perception of gene therapies and vaccines that are designated for HIV treatment or HIV cure. I think that it's very important to think about the impact of this and to preemptively start priming the population that these studies are underway, so that it's not a surprise when ultimately we have these resources available. So to close out, I think that treatment and prevention of HIV has progressed immensely in the last 42 years of the pandemic, but we still have new infections and HIV-related deaths, although thankfully these numbers are continuing to decline. The gains that we've made with controlling HIV are quite fragile and tenuous. You need sustained funding to diagnose, to treat, to prevent HIV. And if we lose the urgency to effectively address these three areas, then we would also very quickly see a reversal of a lot of these gains that have taken 42 years to achieve. I hope that I've convinced you that the search for a cure is active and ongoing. There may be an occasion when I come back to the town hall to talk about vaccines. That's a whole different ball game. And I think it's also important to highlight the theme of this year's World AIDS Day, which was letting communities lead. I think that if we don't engage communities of people with HIV, both in the research, in the science of HIV treatment, prevention, and cure, then we will not have any hope of ending the HIV epidemic. So it's really important to listen to communities, engage them, and let communities of people with HIV and those impacted by HIV tell us what we should be doing to better achieve them, to better help them as we try to end the epidemic. And with that, I'll hand over to the moderators, and hopefully we still have some time for questions. Thank you.
Wow. I don't know if Elvis is still having the connection problems or he's going to be here. So this was a ground round quality presentation. Dr. Boghuma, this was, I think, so much learning and so much knowledge that you presented. So I hope that we had a lot of medical students who could be here, also infectious disease doctors, and generally those in Cameroon could really get to appreciate the knowledge you have shared with us today and the future. as an internist and an oncologist, I've learned a lot about what is going on. So thank you very much for your time. Elvis was doing the moderation. Is he around? If not, I think we're going to give you some time to a few minutes, because we have time issues. Just give you a few minutes for question and answers. And I can see that a lot of what is going on in HIV is really at the forefront of technology, and how to adapt this in Cameroon is going to, or in Africa, is going to be very difficult to get a cure. So I would just like to get a few reflections from those who are in the house, one or two, and then we'll move over to question and answer. So if you have questions, you can always just raise your hand, and I would call based on the first people who raise their hand. So I would love to get a little input from some of you who have been listening, like I think let's see, those who have been here for a while and listening to this lecture, what they think about this. Dr. Folak, what is your take about what you have just heard? You can unmute yourself, please. If Dr. Folak is not there, I would also love to call on Dr. Ivan Zita. I saw him in the call.
Yeah. Good afternoon, Dr. Muno, and thank you for inviting me to make a few remarks here. I want to really start by thanking Professor Titanji for coming on here today to really wow us with her presentation. It's been a long time since I actually delved into the world of HIV, and to see the progress and ongoing work that she presented here today is amazing. And to really know that one of ours is right at the forefront of doing this work is even makes it even much more exciting. As you pointed out, I certainly learned a lot. I was just, when she talked about, is it shock and cure? Yeah. I was just asking myself, what does that mean? I was looking at patients that have maybe a flutter or a feed that need to be shocked. And but when we shock them, the goal is to reestablish them. But she was saying shock and cure. So I was looking forward to understanding what she meant. And thank you so much. You made it so simple. And even folks who probably are not patient enough, I'm sure we're more willing to sit here and listen, because you made the presentation easy to follow, easy to understand. And we cannot thank you enough. Each time I hear that you're on the town hall, I make an effort to come on here. Not that I despise anyone, but sometimes I'm in another meeting, but I try to come because there's nothing more rewarding than learning, a continuous process. So thank you very much, and I look forward to hopefully a very vibrant debate in the answer and in the question and answer session. Thank you.
Yeah, I'll get two more reflections, then I'll go over to Elvis. I'll hand over the moderation to the moderator. So I want to hear from Dr. George Liman, if he's still here, and just one or two reflections. If not, then Dr. Theodore Ngachu.
I'm still here.
Yes, George.
Yeah, I wasn't planning to be here the entire time, but it was compelling enough that I had to answer Professor Titanji. Thank you again. As a pharmacist, we think we know all of what is happening in terms of the mechanisms of action, how these things work. But I think I've learned a lot more about how the thinking around HIV treatment is going. I've been out of pharmacy school for a bit, and so this is a huge benefit for me, because I now work in a space where I'm very distant, but our community needs this kind of information. So I'm really, really grateful I joined, and all these crazy mechanisms, all this crazy science happen. I call it crazy just for the lack of a better word. but just echoing the previous comments, that you made it very, very simple for us to understand. And I just can't wait for what we have in the Q&A section. So thank you.
Okay, thank you. Elvis, can we move over to the Q&A session?
Yes, Mono, and I don't know whether to call it a Q&A session or just to say that we'll be asking her to continue to speak, because I've never attended a session where I don't want somebody to stop and she just literally stopped, because it was just so electrifying. I wanted to hear more. But one thing that caught my attention was the fact that she started on a very positive note by saying a lot of progress has been made when it comes to HIV. And she painted a picture of just how much progress has been made from when HIV was discovered to when we had the first ART, and just how much progress we've made before even going into the challenges that lie ahead. So the floor is open to the town hall. Please, if you want to ask your question, just indicate with a show of the hand, say where you are dialing in from today, and say who you are if that's your first time of attending the town hall. And you can ask your question. Keep it brief and give opportunity for others to ask theirs.
Yeah, Elvis, I put on my hand first. I know I
Go
talk
on.
a lot, but let me talk about this because I really have a question. So in the field of, and I really want Dr. Boghuma to explain to us, in the field of oncology, since I started, we've been pondering and wondering, why are they were doing a lot behind the scenes. Why are infectious disease doctors not using all the strategies we use for cancers? What makes, let's say, for example, HIV different from the different cancers that we are using this kind of therapy that Boghuma has spoken to us about? Immunotherapy, CAR T-cell, CRISPR technology, targeted therapy, and next generation sequencing. So I just want, in a very summarized way, for Boghuma to tell us the complexity. Though cancer can be complex, infectious disease can be more complex. So in the hospitals, we always regard infectious disease as the brainiacs, those who actually know true medicine. Us behind the scene, we are the ones who know complex things, but we don't know true medicine. So what makes infectious disease, HIV in particular, different? And what makes getting CAR T work, getting CRISPR technology work, getting monoclonal antibodies work, and getting targeted therapy work a bit more complex when comparing HIV to the different cancers where we use these therapies?
Since you asked for a short answer, the very shortest answer is HIV is a beast when it comes to viruses. And the more extended and expanded answer to that question is, I mentioned several characteristics of HIV that make it quite difficult to target. It's a virus that has the ability of integrating into your host cell. So whatever therapy that you're using to try to purge out that virus whose genome is within the host cell is challenging to do that. And it's within cells that are healthy. Like these are not cancer cells. These are just white blood cells that have integrated into their genome the HIV provirus. So when you're using a chemotherapeutic agent or an immunotherapy for cancer, you're looking to kill aberrant cells that are cancer cells. These therapies are not necessarily directly targeting healthy cells that are not cancerous cells. And in bringing some of these approaches into HIV, you're dealing with the challenge of trying to use them to target HIV within T cells that are not cancer cells, but at the same time minimizing the side effects that come from these therapies, because there are lots of off-target effects that can be seen with a lot of these therapies. So that's the first issue. The second issue is that HIV, when you think about monoclonal antibodies, neutralizing antibodies, HIV has a very, very rich genetic diversity, meaning that it exists in many strains and forms. And when you have antibody-based therapies, they have to match what you are targeting. Think of an antibody targeting a virus or a bacteria as a lock that has its key. So with HIV, you may develop the key, but the locks are different. It's like a million locks that exist out there. So that key may work to open 10 out of 1 million lots. So that would make it challenging to get a monoclonal or neutralizing antibody therapy-based treatment that would be one unique treatment to target everything. Coming back to gene editing, which particularly whether you're using zinc finger nucleases or you're using adenovirus vectors to deliver editing systems, or you're using CRISPR, the goal of gene editing in HIV is to try to go into that genome and excise the HIV genome from your cell's genomes. That is challenging to do when you have a virus that doesn't really have any rhyme or reason as to where it chooses to integrate into the genome. Again, with gene therapy, something like CRISPR, it's meant to be very targeted. If you have sickle cell anemia, people with sickle cell anemia, we know the mutation. It's that one mutation. You can go in and very targeted excise it. There's a study that came out just 1 week ago in the Journal of Virology that actually showed that using CRISPR for HIV is something that we have to tread with caution, because it showed that in trying to, in an in vitro-based study, trying to apply CRISPR to edit HIV-infected cells, there were lots of off-target editing that cut off pieces of genes that are important to our functioning. So again, those therapies may be less safe if they're not properly studied and properly targeted in the HIV space compared to in other spaces like cancer. So that kind of summarizes some of the difficulties with the different approaches, and, you know, succinctly put, HIV is a beast.
Wow. One last follow-up question, just one. Like in our cancers, we do know some cancers have don't kill me signals, like PD-L1, like programmed dead ligands. Do some of these viruses also develop don't kill me signals? I'm just going generally in virology, don't kill me signals that we could target and say, okay, we open them up to the immune system to see them better and kill them.
One of the immune therapies that we're looking at for HIV is PD-1 blockade. So yes, HIV and PD-1 itself is a 2-hour lecture. Which,
okay. That I could help with that lecture. So Elvis, thank you. I'm done.
Great. Thank you, Mono, for asking those very important questions. And I'm really glad that you know, Professor Boghuma was able to give those very simple but really interesting responses. We have George Ngok, please. You have the floor.
Oh, thank you. Am I being heard?
Yes.
Okay. I want to thank Prof. Titanji for this very educative lecture. I'm telling you, as a surgeon, it's a long time I've had this kind of teaching on HIV. So quickly, I have just 2 questions, and I just
and John, before your question, where are you dialing in from? Just maybe
I'm sorry, I'm from Cameroon.
Okay, great.
Yes, I'm Cameroon. So, Prof, great. My first question to you is concerning the pre-exposure prophylaxis. I'm just wondering whether, from what you know, have there been any evidence to show that pre-exposure prophylaxis has something to do in terms of increase in other venereal diseases? Because it doesn't prevent you from having other venereal diseases, but I'm just thinking in terms of the behavior, does it predispose people to not take cautions on being effective from other venereal diseases? And also, I didn't hear you talk much about post-exposure prophylaxis. I don't know whether that one is not being looked at that much, or is there still any benefits in it? Because I know that, except I'm wrong, I mean, you correct me, I know that it also depends on the time that you will take the drug after you have been exposed to the virus. Thank you, Prof.
Thanks for those questions. I'll start with the shorter one. Post-exposure prophylaxis still works, it's still delivered, it's still effective. And it is ideally administered within 72 hours of an HIV exposure to reduce the risk of that person who's been exposed either through a needle stick injury or other blood exposure to mucosal surfaces it reduces the chances of that person getting HIV or going on to develop HIV. And in those instances, we're using drugs that are used for treatment. So you would get maybe one of the once daily pill options, and you'd be given that medication for 28 days. And generally, post-exposure prophylaxis is still about 99% effective, and highly recommended if someone has a credible exposure to HIV. If you see them within 72 hours, there is benefit in offering that intervention. I didn't spend a lot of time on it because post-exposure prophylaxis is usually that the occurrence or kind of like the instances where we have to use them are usually in a healthcare setting, or people who've been exposed to someone with HIV, either through a sexual encounter, showing up to an emergency room. And these instances are not quite as prevalent as the numbers of people that need to be treated for HIV, or the people who are at high risk for HIV for whom we need to give pre-exposure prophylaxis. So I just wanted to make the talk more focused. That's why I didn't talk about PEP. The first aspect of your question was whether having access to PrEP makes people more promiscuous. You are asking the question to a sexual health professional as well, because, and for me, I don't care how much sex people are having. It's not my role to police the amount of sex people are having. People are free to have as much sex as they want. The goal is to make sure that they are able to be safe and free from disease while having the sex that they want to have. So I think that that's a very dangerous area and conversation, because it stigmatizes the use of pre-exposure prophylaxis, and has actually been the reason for some of the low uptake of pre-exposure prophylaxis among certain communities. Like women in Africa, there are studies that have shown that women in Africa, young women in Africa, may not want to take pre-exposure prophylaxis because of the perception that it may reflect on their sexual behavior of whether they're being promiscuous or not. But you may have a young woman who is not promiscuous, but has a partner who has multiple other partners and is taking pre-exposure prophylaxis to prevent herself from acquiring HIV from a partner that may be higher risk. So a lot of the studies that have been done around PrEP has shown that it doesn't really modify people's sexual behaviors. And I just want to emphasize that tying PrEP or use of PrEP to promiscuity actually reduces uptake and defeats the purpose. The goal is to make PrEP available to those who want it and are likely to benefit from it because they are at a higher risk of HIV exposure and acquisition. I hope that addresses your questions.
Yes, Prof. I think it's quite clear. Thank you very much.
Very great response there. Very great response there, Professor Boghuma. And you said something very interesting. And I like the fact that you said you don't mind about how much sex people have, but the important thing is they should know exactly just what exposure they are and take precaution. But look at this. When HIV started, one of the challenges that we have with HIV is the narrative when it started, when HIV, the equation was HIV equal to death. And that was the very fundamental beginning of the problem of stigma, which has carried on with HIV treatment and diagnosis and everything along the continuum of care for HIV, stigma. Because the equation was HIV equal to death. Even when HIV was not equal to death, no one believed it anymore. It took a long time, even when HIV antiretroviral was discovered, for people to believe that that equation was not true. Now look at the way people, PrEP is being defined, or you say it's for people who are at a high risk of having HIV. The way the narrative of the use of PrEP itself was conceived when PrEP was discovered stigmatizes its use, because it's not about the lady who maybe has a promiscuous partner. That's part of the risk aspect, but it's about the person who is at risk, because they say either men having sex with men or those who are promiscuous and have multiple partners, those are the ones who use PrEP. So don't you think, Professor Boghuma, that the way the population that are supposed to use PrEP have been defined actually stigmatizes the use of PrEP itself?
Absolutely. And I'm really glad that you raised that point, because it ties very nicely with the theme of World AIDS Day, which is letting communities lead. And communities of people with HIV, people with unique risk profiles, or people who are vulnerable communities like younger women, have been telling us, the people who deliver HIV care, to stop calling them high risk, because that in itself is stigmatizing. So there's a huge movement towards trying to destigmatize how we label people, because those labels have negative connotations, which impact our ability to deliver these tools to communities. It becomes almost as though PrEP can easily become a scarlet letter, right? Like basically a mark on your forehead. If you see somebody going to that PrEP clinic, that girl is like that, she sleeps around. That becomes something that can, lead to people, dissuading people to go and actively seek care. There are also studies done in Southern Africa that have shown that in some of the PrEP delivery studies for young women, use of PrEP and delivery of PrEP was also associated with increased intimate partner violence, in the sense that you have a male partner finding out that someone may be using PrEP to protect herself, and that person then immediately starts maybe violent towards their female partner, because they think that the use of PrEP reflects that their partner is not faithful to them. So these are all conversations that I'm glad we are having, because there's certainly a huge need to destigmatize how we frame pre-exposure prophylaxis and to make it more broadly appealing. It should not only be that, oh my God, it's for people who are high risk. And we have to stop calling people high risk. Maybe call people who are more likely to be exposed to HIV, which could just be young people who are having a lot of sex, right? As opposed to saying high risk and then siloing it to sex workers and men who have sex with men.
It looks like Elvis went out again. Wonderful response. Just as being an infectious disease doctor, researcher, HIV researcher, going back to this question of PrEP, do you think we're going to get to a point where PrEP will just be any other available medication where anyone should be able to prescribe it to whoever thinks they want it?
Well, I think it's not restricted to ID doctors at all.
Okay.
In the US, you as an internist can prescribe PrEP.
Okay.
The problem with people not prescribing PrEP is that people fear HIV medicine and don't want to learn about HIV medicine. So they see patients and then they refer them to us for PrEP. Absolutely. No, actually, a hospitalist, say for instance, in the US, if you're discharging a patient that you have seen maybe for an STI, let's say for instance, I admit a patient for disseminated gonococcal infection. And then in my conversation with the patient, they tell me, oh yes, I have many casual partners, or I have casual partners. That is somebody who qualifies as for PrEP. And that person should not leave the hospital without a prescription for PrEP. But there is a dissociation where PrEP has been thought of as restricted to people within HIV care and HIV medicine. Sexual health nurses should be able to prescribe PrEP. GPs should be able to prescribe PrEP. It is just a pill with 2 drugs in it for prevention. Yeah. And I'm hoping that we would move to a point where it can be dispensed in the pharmacy, like, going into a store and buying a condom. The only issue is that because these are medications and because they're antiretroviral medications, it's important to get a baseline HIV test to make sure the person doesn't already have HIV. Because if you give them PrEP when they already have HIV, you are partially treating their HIV and you would select for resistance. And also while they're on PrEP, it's important to periodically screen them for HIV so that you catch an HIV acquisition if it happens. Because of course you're prescribing PrEP to people who are healthy. So the adherence is never 100%. And people can forget to take their PrEP and then still get HIV, although technically they were on PrEP, which is why the long-acting formulations are really exciting, because then they don't have to think about taking a pill for pre-exposure prophylaxis. They can get an implant that will last them a year, and you just have to do their periodic STI screening and HIV testing.
Wow. So you see, even being an internist here, I never knew I could easily prescribe it. I don't know if you do get authorization needed, but I would call on Acho to ask this question. Elvis is back. Okay, Elvis can take over. Dr. Acho Abongwa, then Marie after Acho. I know for the sake of time, I don't know how long Prof. Titanji wants to continue. Tell us. Sure. Respect that.
I can go on for a little bit longer because
absolutely.
I'm aware that my talk took more than the 1 hour.
Yes, so we'll give a little bit more of 30 minutes because she's very busy. So Dr. Acho, first, your questions, please.
All right. Thanks so much, Doc, and thanks so much, Prof, for the excellent presentation. Acho, I'm calling you from Kribi, Cameroon, and I'm also in HIV service delivery, so this was really big for me. I just want to ask, we noticed a lot of the clinical trials and on HIV cure, HIV vaccine going on in Africa are focused more in East and Southern Africa. What could Cameroonian researchers or those in research in Cameroon do to make Cameroon a more attractive location for HIV vaccine cure research, given the diversity of virus in our setting and all that? So that's maybe a question, maybe how we do advocacy for that, how can that be structured? And second question is maybe just a call for a comment. If you remember, when the HIV pandemic started, one of the early people started talking about HIV in the space of immunotherapy was Professor Nomangu. I don't know, did you have a comment about that, or Vanivax, was it ahead of its time, or I don't know, just what are your thoughts about that? So that's just the second is to go for a comment. Thank you, and over.
Thanks for your question. Regarding the first question as to how HIV clinicians and researchers in Cameroon can get involved, that's the beauty of the town hall. You know, first of all, the first thing is being aware that these studies are happening and already having an interest in potentially being engaged in as an investigator or a co-investigator in these studies is important. Historically, Southern and Eastern Africa have had a higher burden of HIV and still have a higher burden of HIV compared to West and Central Africa. So a lot of the studies or clinical trials for HIV were conducted in Southern and Eastern Africa because they had such a large number of patients and an easy way of recruiting patients into these studies. Additionally, they also have a more robust clinical trials and clinical studies field, like basically landscape, because they have better ethical regulation and clearance. They have really strong community engagement and groups that are already primed and quite familiar with participating in research and being able to engage with some of these studies. This is something that we desperately need to strengthen in West and Central Africa. And I'm glad you brought up that question, because that's what DAC-A is trying to do in Africa, is to help countries that are not represented in clinical trials to the same extent as countries in the southern and eastern parts of Africa, to be able to build the type of capacity that allows our own investigators locally in Cameroon to start participating in some of these studies. Because as you mentioned, the diversity of the virus is such that it doesn't serve us if we're only studying it in certain populations. So it's very important that we strengthen our clinical trials networks and develop investigator skills that allow investigators in Cameroon to be able to lead some of these studies within our country. It comes down to reducing the amount of regulatory barriers that exist either at the level of the ministry or the healthcare
and please
system,
don't forget,
to
we
allow
still
people
have
to be able to
our
set up clinical trials, but
parking
also
lot session.
training investigators so that they know what it takes to run a clinical trial. I work running clinical trials and doing research that complements clinical trials. There is a skill set that you need to be able to effectively recruit, monitor, and report on clinical trials. And I think that we need to strengthen and build this capacity to be in a position to say, hey, we have an HIV treatment center that caters to, I don't know, 3,000 people with HIV. We want to be able to participate in this study, and we will have the ability to participate as a site for the study. There's a long way to go. It's a nightmare trying to get any clinical trial started in Cameroon. And that would take, impacting different areas to be able to get our ducks in a row so that we can be more attractive and competitive in this areas. The second question that you mentioned is, the comment I'm going to make is, you're right, some of the therapies that Professor Anomangu was using in his Vanivax were what is very similar to the CAR T cell therapies that I described, and the therapies that require taking cells out, modifying them, and reinfusing them to the patients. But I don't know exactly what sort of modification he was performing on the cells of the people that he was treating in his clinic. So unfortunately, in looking at some of these studies that were published, it's very difficult to gain an understanding of what it is that he was doing with those cells. And I think that maybe that was done as a way of intellectual property, protecting his intellectual property, but also not reporting on them in a manner that was kind of transparent and accessible to everyone, may impede us from being able to recognize that maybe he was a pioneer in this area that is now kind of being revolutionary in the HIV cure space, which should be a lesson for all of us, is that if you're working on something that is innovative and you think that you actually have a cure, you have to disseminate that knowledge. You have to be able to publish it in a manner that you can then claim credit for it when it is shown to be effective. And we have, our own journals. If you say he couldn't publish it in foreign journals, there's the Pan-African Journal of Medicine, there's the Journal of the National Academy of Sciences in Cameroon. These are all avenues where, if they had been published, these would still be indexed, and we will be able to go back and read what he was actually doing and see how similar it is to what's being rolled out now. But hindsight is always 20/20, and I guess we'll just never know. So that's my comment.
Wow. Just a follow-up comment. Do you think?
Thank you very much,
Yeah. I want to ask for a follow-up comment. Do you think that the help, if we had a help of a virologist or someone who was doing HIV research and who could write up some of this studies or things that he was doing, would have helped? Or teaching the young generation how to publish and write papers would have helped the situation where we find ourselves with people like Professor, what's his name? Anomangu.
Yes, I mean, absolutely. It goes back to having a young generation of investigators who have the skill set not only to carry out the research, but to also effectively disseminate it. And that's what we're hoping to do in the town hall. Pique the interest of people who might be interested in HIV research to be like, oh, this whole research thing sounds fun. I want to be a part of it. How do I develop my skills so that when I start doing research in my own environment, I can properly be credited and also disseminate the knowledge that I'm finding. So definitely would have made a difference, because you can say he was curing people from HIV, but I'm a virologist. I want to be able to pick up a paper, a manuscript that he wrote, and actually understand what the modification he was performing on those cells he was getting out from people with HIV was before reinfusing the cells. Like, what was it? Was it CAR T therapy? Was it gene editing? What was it? Like, and with that knowledge gap, there's no way of me saying, oh, this guy was curing HIV in Cameroon, because I don't have the evidence to be able to win a debate on that question.
Sadly, he went into the grave with it. Very sad. And
well, partly, Mono, let's put his research into timing. His study started at a time when everyone was striving to be pioneer and I have the accolade as the person who discovered a vaccine or a cure for HIV, which of course, and there was a trust issue here. There was a trust issue here because Anomangu was operating in a situation where, being an African and being a Black man, he feared that his knowledge was going to be taken over and maybe replicated by some people who never even give him credit. So he operated science. Of course, that's not how science operates. Boghuma testified, you must read the evidence, you must see it published. But he operated science within a confine of confidentiality, which does not happen in science, because of trust issues that existed within that.
But Elvis, to your point, and kind of like a counter argument to your point, Professor Anomangu also was a winner of the Lasker Prize, which is I would say the second most prestigious prize in medicine after the Nobel Prize, for his work on Burkitt lymphoma. It's one of the only Africans, I think is the only African scientist to have won the Lasker Prize. And to show you how important the Lasker Prize is, 1 out of 5 winners of the Lasker Prize go on to win the Nobel Prize. So he had already demonstrated in the field of cancer biology that he knew how to publish and disseminate and get credit for his research. It's just unfortunate that the same didn't happen with his discoveries around HIV.
Wow. Wow. Okay, let's, Marie.
Thank you. Let's get out of that topic, and Marie's up. No, Mono, feel free to take it away from me. You know, I'm in Zambia, the network is bad.
Yes,
Anytime
the network is bad,
please
and
take
you're
it away
coming
from me. Marie.
yeah, so, but Marie, unmute yourself, please.
Okay, can you hear me now?
Yes, we can hear you, please.
Okay, my name is Marie Massing. I am a clinical pharmacist here with an Indian Health Service, and I'm specialized in HIV medicine. So this was an amazing presentation. Thank you for the information. I do prescribe PrEP in one of our clinics that we have here. Yeah, so based on risk factors, we get referrals from providers. You don't have to be an IED doc to prescribe that. So we encourage that so we can remove the stigma for a lot of people who can have access to it. The question that I actually have 2 questions for you. One of them, when it comes to PrEP, obviously we talk a lot about just Truvada. That's what people know a lot. So in your practice, have you seen the use of Descovy? And because when we talk about Truvada, we talk a lot, I counsel my patient on the potential of a kidney, decreasing creatinine clearance and all of that. But with Descovy, that's a difference, and that's an advantage. We don't have that in our practice. But in your practice, have you prescribed or have a patient who uses Descovy? And if yes, does it have any effect on any metabolic changes or diseases?
Yeah. So just to kind of give insight to those who are listening to the call, Descovy contains tenofovir disoproxyl fumarate, which is a formulation of tenofovir with emtricitabine, whereas Descovy contains tenofovir alafenamide in combination with emtricitabine. And that different formulation in the tenofovir component of the PrEP pill reduces the renal effects that tenofovir disoproxyl fumarate has, the one that is found in Truvada. So that is kind of like the difference between the 2 options. Essentially very similar. It's just that in the more updated version of the pill, that particular ingredient, the form has been modified and is associated with fewer renal effects. In my clinic, yes, we do use both. And we basically counsel patients on what their options are. We have Truvada, we have Descovy, and then the patient makes an informed choice of what they prefer. Some patients coming to us have already been on Truvada at another PrEP clinic, maybe in another state, And they're like, yeah, this has worked well for me. I've not had any issues, so I'm happy to continue with it. Others, when you're initiating, they hear about the possible renal effects of Truvada, they opt for Descovy. But Descovy is not without its own metabolic effects. There's now studies that are showing that tenofovir alafenamide may lead to metabolic issues. We don't quite understand the mechanism by which, but there has been associated weight gain with that tenofovir alafenamide component of Descovy. So that also may be something that individuals who are taking a Descovy-based PrEP may notice that they're gaining weight, which of course then comes with increased risk for that type 2 diabetes, high blood pressure, and all the other risks that you incur with obesity, which is also another consideration for what may skew someone's preference for one or the other. And I think that in having the conversation about PrEP, the challenge is always the fact that, remember, you're giving PrEP to someone who is not sick. So it's a prophylactic medication, but you're exposing the patient or the person to adverse effects that can come with taking that treatment. So it's always a balance. It's like, what's the risk benefit of exposing this person to potential adverse effects versus reducing their HIV risk? And reducing the HIV risk absolutely makes the risk benefit ratio a lot. It's a no-brainer, because the instances where tenofovir leads to kidney injury tend to be low. And even when people have weight gain on Descovy, it's not everyone who gets weight gain on Descovy. And remember, a lot of these effects can be reversed if the medication is discontinued. So it's not like the change to the kidneys is permanent. Tenofovir disoproxil fumarate causes kidney injury or whatever through it's a Fanconi syndrome. It's reversible when you stop the medication, right? So it's another reason why we monitor people's kidney function when they are on Truvada, to make sure that we're not seeing a rise in creatinine, and so we can promptly discontinue the medication if someone is developing an adverse effect.
Wow, thank you. I'll just move over to the next person. There are several hands up showing that. I'll go over to Mokwele Julius and then Dr. George Lehman. Please take over. Unmute yourself, Julius. Just be brief, please.
Dr. Mekole, I work with HIV service delivery here on it, where we're programming ARV dispensation through community pharmacists, and of course, with the involvement of PrEP for prescription at the pharmacy. I must say, Prof, I'm a big fan of yours, following up with your very brilliant write-ups on LinkedIn. And then back to my question, I think I dropped it on as a comment. I looked forward to, anyway, I followed your discussions on the various formulations, the various researches which are ongoing for the treatments, the 6 months and all the like. But one thing I noticed was that most of these presentations were they were mostly adult friendly, and not really children, not friendly to the pediatric population, which of course we know seems to be the forgotten lot in our setting. So I was just looking forward to you talking to that. Thank you.
Thanks for that question and for your very kind compliments. Yes, unfortunately, a lot of the studies that have looked at the different HIV therapies tend to disproportionately focus on the adult population. And that is an area where we are failing children with HIV. We need to do better in finding formulations that are well adapted to children with HIV. Interestingly, cabotegravir, rilpivirine injectables are approved for use in pediatric populations. It's just unfortunate that we have not yet gotten to the point where these formulations are becoming more widely available in the African setting, because of course, this is a new drug. It's still on patent. So it makes it very difficult to produce generic versions of the drug that would be available in the African subcontinent. That being said, some of the single pill options and the different available adult formulations due to advocacy from pediatricians and general physicians who care for children with HIV, we're now seeing a lot of pharmaceutical companies begin to carry out studies specifically looking at pediatric-friendly formulations. So I'm hoping that that is a gap that we will see covered or bridged in coming years, because it's also a big area of focus for UNAIDS to close that treatment gap. Only 52% of children with HIV globally are getting treatment as compared to 75% of adults. So we need to do better in addressing the pediatric population. So advocacy counts, and it's being heard by the pharmaceutical companies that develop these drugs. And I'd also like to add that, you know, besides us just being saying that pediatric populations are forgotten population, it's important to highlight the fact that carrying out studies in children adds an added layer of ethical considerations, because in these instances, you're having to consent the parents because the children are not old enough to be consented for the studies. And sometimes in populations where there's a lot of misinformation and disinformation, that may be a barrier to being able to recruit the types of numbers that we need in these studies to show efficacy and safety one way or the other. So that's another area that we have to actively work on, educating parents of children with HIV on the importance of allowing their children to participate in these studies so that we can identify what works for the children and get better options available in the pediatric space. Over.
Wow, thank you. Let's just keep going because you have just 10 minutes. Dr. George Liman.
Yep, let me come on camera now. I wanted to make a comment, especially when they're talking about research in Africa. I just dropped a link because one of my mentors is currently in Nigeria for a research-focused conference. And my understanding is that they are trying to get partnerships with different pharmaceutical companies to advance research, especially in sub-Saharan Africa, because in most of the studies we have so far, you see Africa represented, but it's mostly South and Southern Africa. So that for people who are interested, who are based in Cameroon, maybe they can follow up on that conference, see where it's going to happen next. But many pharmaceutical companies are making increased investments in training clinicians, researchers in sub-Saharan Africa, just to improve the diversity in clinical trials. That's what I just wanted to add. And again, Professor Boghuma, thank you for this great treat.
Hey, over to you, Boghuma. Any response?
No, I think that's great. Thanks so much, George, for adding the link and for sharing that opportunity. And I'm hoping that members of our audience that are in the HIV space and HIV adjacent spaces would certainly click on the link and follow up to see what comes out of that.
So the next is Dr. Geoffrey Shu, please. Over to you. Unmute yourself.
Okay, good evening to everybody, and thanks for giving me the floor. I want to start by appreciating the great presentation done by Dr. Boghuma. And I just want to ask two questions. I have two questions. The first question is a clinical question, and it's a general question. It's not maybe focused on this presentation. You know, when we talk about HIV is a very sensitive topic, a sensitive issue, especially among couples. I want to ask that in a situation where you receive a couple, you are consulting the hospital, and you receive a couple who come for HIV screening, and you know one of them is already HIV positive, and she knows, maybe the partner knows that he's HIV positive, and he refuses to tell the partner, to inform the partner, and then you screen both of them, and one is positive, the other one is negative. So I wish to find out how, if like you want to disclose the result and the other partner is refusing, so she doesn't want the partner to come to knowledge that she has HIV. So what approach can you use to maybe prevent the partner from contacting the HIV virus? And then the second question, is on PrEP. It's based on PrEP. I did not really get the section on this, the presentation on PrEP. Maybe I came a bit late. I wish to find out if it is possible for future research to maybe focus on on coming up with drugs that can maybe inhibit or that can cause apoptosis in the glycoprotein 120 in the envelope receptors, because we know that the HIV virus uses these envelope receptors to enter into the cell. So if we can create drugs that can cause apoptosis.
Okay, George, for the sake of time, let's allow, I think your question is clear. Let's allow Prof. Boghuma to answer them.
Yeah, I'll start with the second question. You're asking about co-receptor blocking agents. We already have monoclonal antibodies that target the envelope glycoprotein. They're drugs that target GP41 and fervitides, an old HIV drug, is over 20 years old. And they're now also in development drugs that target GP120. And they're in the pipeline being looked at, but they're more in preclinical studies, so still animal studies. And I didn't want to spend this hour that we had focusing on very early stage studies of drugs. The talk is recorded. I had 40 minutes talking about different options and treatments in the pipeline for pre-exposure prophylaxis. So you can actually go and watch the talk and catch up on that section if you missed it. Going back to your clinical question of discordant couples, the answer to that question is, firstly, it depends on the laws in the country where you are practicing medicine. What are the HIV laws, the laws about HIV criminalization in Cameroon? Is it a criminal offense if someone has HIV and does not disclose to their partner, and that person subsequently gets HIV from them? In some countries, it is criminalized. In some countries, it is not. So I would tell you to look up what the Cameroonian Penal Code actually says about exposing someone to an infectious agent if you know your status and you fail to disclose, because that will guide the type of conversation and how you counsel a discordant partner in a discordant couple on disclosing. So I would take the case of Georgia, which is the state where I practice. It is, HIV unfortunately still is criminalized. I don't believe that you should criminalize people for having a disease. But I do think that people with HIV who have HIV should be able to disclose. And in instances where I have that discordance, I remind patients that there is actually a criminal penalty if they fail to disclose. As an HIV provider, I am not obligated to notify the other partner. So again, you have to look at what the Cameroonian law says about this and then help guide your conversation. So what I usually do is I try to focus my discussion around emphasizing the fact that on U equals U. So if the person who is infected is treated, they have zero chance of passing it on to their partner. Secondly, I try to destigmatize the concept of HIV infection and HIV seropositivity. And then if it is criminalized, I make sure I highlight the fact that by not disclosing, they may actually be committing a felony and be liable to spending time in jail for exposing someone to HIV. It's never an easy conversation. As your part as a clinician, you're not allowed to go and disclose. That is bridging the ethics of clinical practice, but you can focus on counseling. In my experience of working in HIV care, I've hardly seen an instance where over time that counseling wasn't effective in ultimately getting that person to the point of being able to disclose to their partner. In some instances, it takes time, several months and several visits, but I think patience and developing a relationship of trust with the infected partner ultimately gets people to a place where they will disclose.
Yeah, thank you. And the last question, just good to remind the audience that Prof. Boghuma has experience in working in Cameroon, in Lakentini, experience in working in the UK and in the US. So it's good for you guys to know. So she worked in Cameroon in HIV too for a while and did a lot of HIV research. So the last question goes to, oh, the hand was up. Did she just leave? Oh, so I was looking at one person's hand was up. Any other person? There was one person whose hand was up. I didn't get the name. And last question. If not,
maybe I answered their question in my previous, yeah.
Yeah. So, and if Elvis is not around, then I think it's time for us to round up. I'm around. Oh, Elvis, take over.
I'm
please.
around.
Elvis, take over.
Can you hear me? I'm going to take over.
Yes,
I'm going to take over, and please forgive me if you don't hear my voice. No, I'm disconnected by the port network here. It's been a great session. Thank you so much, Professor Boghuma, for a wonderful session. She started the session by just, telling us the situation of HIV. There are still 39 million people with HIV, and in 2022, we had 1.3 million people in million infections and 630,000 dead due to HIV, and still about 39 million people living with HIV. That was the global statistics Boghuma gave us, and a lot of progress had been made. She recognized this fact, but also regretted the fact that 52% of children with HIV do not have access to treatment, and that's 77% of new infections globally within the ages of 25 to 34 age group. People are still women and girls in Africa. This is really, really a sad situation. And that in Cameroon in 2022, there were 9,900 HIV infections, 480,000 people with HIV, and 420,000 people currently on HIV treatment. And that the national prevalence.
Okay. Looks like we lost Elvis again. So while Elvis was giving a summary and the closing remarks concerning Prof. Boghuma's presentation, we can all go back, look at the presentation. I want her to give her last goodbye message. And there is the last one.
I think that was the person who was trying to ask a question.
Hello?
Yeah. Yes, Elvis? Okay, yeah. So Dr. Mukumapa, you can ask your last questions. I think that was the person who was, we gave her the chance for the last question. Then Elvis is going to continue with the roundup, if that's possible. You can unmute yourself, please, just briefly.
Thank you very much. And I thank Dr. Titanji for the talented and well-organized presentation. Actually, it was very good. I'm from Cameroon. I'm Doris Fru from Queen District Hospital, Bamenda. Actually, the presentation has moved me. And I quite reflected on the fact that the health experts are doing a lot to reduce HIV in our communities. But we have a group of men, religious men, and some traditional healers who claim they can treat HIV, and they tend to frustrate our patients. I wish to ask the doctor, what is your impression about this? And what strategy are you putting forward to at least go against this immoral behavior? Thank you very much.
Thanks for your question, and thanks for coming to the talk. It's a very challenging situation. We're experiencing misinformation and disinformation, not only where it concerns HIV, but across the spectrum of diseases that we deal with, even involving vaccines or, the same groups of people that you mentioned, some religious groups and some traditional medicine groups, dissuading people from getting their children vaccinated. My answer and kind of like my approach to this is kind of always reminding people that knowledge is power. You cannot fight misinformation and disinformation if you yourself do not master the knowledge, because you would not be able to competently counter the arguments that these people use or properly educate your patients. So I think that the first step is doing what we're doing now, coming to forums like this and actually getting the knowledge disseminated so that when you go back and you talk to your patients, you can be compelling in your argument, convincing in your argument to make sure that you highlight the fact that they are being exploited by people who may not even know what a virus is and how HIV infects or establishes infection. So we can't be discouraged. We can only keep doing the work, but it is the new landscape that we have to navigate when infections and the treatments for them are concerned, is misinformation and disinformation.
Okay, over to Elvis. I think for conclusion, then Dr. Boghuma, let's go.
Wrap up.
We kept losing you, yeah.
Yeah, I think not to bother our audience, I had a good summary to present, but I think I just give the chance for us to do a simple conclusion so I don't go over it and get cut off again with the bad network. But it's been a great session and we'll learn a lot. She's taken us through all the developments in the history of ART and the development that has taken place. And we are happy that we have left from 3 combination therapies of 3 different molecules now to just having them in one form, some given as medications that can be taken as pills, maybe injectables for over a long period of time. She's walked us through all those landscape. I don't want to go through a lengthy summary that I did here, but I think I want to just thank Boghuma for walking us through the journey of all what has happened in the arena of HIV. And I'm very happy when she took us through the pathway to cure and just letting us know the different advances in research that are going on. We're really happy, especially when she mentioned the 4 main approaches to cure, which is the shock and kill, gene editing, lock and block, and the immunotherapy. I think you've just given us so much to take home, and I want to say thank you so much for an excellent presentation.
Last words, please.
No last words. Anytime I have time, it's always
a very good
spending time with you all in the town hall. So thanks for the opportunity again, and I look forward to next time.
Yeah, we want to thank you for your time. We want to thank you for your sacrifice and your dedication, especially as one of our participants said today, what you do on LinkedIn, what you do on Instagram, and what you used to do on Twitter, which is to advocate for change in Africa, change in the way research is carried out. And our next session is going to be no one other than our own moderator, Elvis Ndesi, who is going to talk to us about a special project, which we all have made note of during this presentation about how do we get research running in Cameroon, Elvis. So this is going to be a special session, and I want to say that we have just 15 minutes in the parking lot, and thank you, Boghuma, for everything you've done.
Pleasure. Thank you. Bye.
Bye.